And now to introduce Dr. Kathy Masis. Dr. Kathy Masis returned to Greater Cleveland in 2021 after serving in the Indian Health Service as a commissioned officer in the U.S. Public Health Service from 1985 to 2006. She and her family were stationed on the Navajo Reservation at Tuba City, Arizona, and later in Billings, Montana. Dr. Masis holds degrees in nursing and medicine from Case Western University in Cleveland and a master's degree in culture and spirituality from Holy Names University in Oakland, California. She practiced nursing at the Free Medical Clinic of Greater Cleveland and did her family practice residency at Fairview General Hospital before serving in the Indian Health Service. As medical officer for behavioral health for the Indian Health Service Montana, Wyoming area, she worked with the Indian Self-Determination and Education Assistant Act of 1996 contracted tribal health programs of the Northern Arapaho, Eastern Shoshone, Northern Cheyenne, Crow, and Blackfeet tribes, the Fort Belknap Indian community of Grovant and Assiniboine tribes, and with the Fort Peck, Assiniboine, and Sioux tribes, as well as with the behavioral health services at 4 urban Indian centers in Montana. After her Indian Health Service retirement, Dr. Masis was employed by the Montana Wyoming Tribal Leaders Council until 2012. Stephanie?
Hmm. Mitakiapi. My name is Stephanie Ironshooter. Hello, relatives. My Lakota Cree name is Makpiazi Iotaka. That means yellow cloud sitting woman. My English name is Stephanie Ironshooter. My mom is from the Fort Belknap Indian Reservation, where I'm enrolled as an Aaniih, and my dad is from the Rosebud Sioux tribe in South Dakota. That is the reason why I introduced myself that way. Just to explain to this audience, is we were taught to bring forth the reason why we're in the world. And the reason why we're in the world is our parents and our ancestors. So we introduce ourselves in a way that describes where we come from and what our DNA is, what our makeup is as a human being on this planet. My career since the early 2000s, late 90s, early 2000s has been really to serve the American Indian population in a lot of capacities: domestic violence, substance use prevention, substance use treatment, suicide prevention, mental health, behavioral health prevention, training. My whole career has been based on serving the American Indian population here in the state of Montana. And for a brief time with working with Dr. Masis, actually, at the Montana Wyoming Tribal Leaders Council. At the time, it is now called the Rocky Mountain Tribal Leaders Council, that served both Montana and Wyoming tribes. The mission of that organization was really to serve large land-based tribes. So all the tribes that we served when we were there, actually, it really morphed into or evolved into a more of a healthcare organization rather than large land-based tribal support, which a lot of our tribes in Montana are not large based tribes. I think there's only like 3, maybe 4 that are large land-based tribes. So it was really cool being able to work with Dr. Masis in the healthcare arena in many different areas and serving our tribal people here in the state of Montana and Wyoming. My previous position as the American Indian Health Director for the state of Montana really led me into what we're going to discuss today, which is really about health equity, health disparities, the disproportionality of those among American Indian populations, not just in Montana, but you're going to see in this region. I mean, across the United States, it's very disproportionately higher than the white population. And that's our comparison in Montana, as we are the second largest population in the state of Montana. I am a mother, a grandmother, a wife, and a fur baby mama. My daughter is Magaju Ironshooter. Her Lakota Cree name is First Heaven Thunderbird Woman. I'm still practicing on how to say it in Lakota. So I am currently learning my language, my Lakota language now. And I grew up grew up traditionally Cree and Rocky Boy. I'm not Cree, but that's how I grew up ceremonially in Rocky Boy. Um, so my granddaughter, her name is Logan. She's 5 months old. And my son-in-law is Guatemalan, and my daughter is in the United States Marine Corps serving active duty on Camp Pendleton in San Diego, California. So, and then I got my two fur babies, Max and Bunny. They're both males, and I love them to death. And that's why I'm going home at this late hour. I want to get home to them and cuddle with them. They're lonesome for me. And I really appreciate you all being here and allowing me to introduce myself and share our experiences with you. So, Wopila.
Thank you.
Thank you.
Before we go on with our the presentation today, so I'm going to share my screen briefly for a brief, let's see if there's something I need to do here. Just a very brief history of the American Indian peoples in Ohio. I'm going to try to run through this pretty quickly, so hold on a second. Can everybody see this screen?
It is on the screen. Yes, we see it.
I need to get this thing out of here. Well, for me to see. Anyway, I'll go through it quickly. Because I know there's much to say here. So many of us are familiar already with the ancient tribes. Oh, I keep getting, excuse me, I need to get rid of this thing, but oh.
You could just go through it. It's on the screen clearly.
Okay, good. Many of us are familiar with the ancient cultures of the Aaniih and Hopewell, those of us who live in Ohio, whose mounds are still found in the central and southern Ohio. So I'm going to jump from the ancient times to the modern era, and you'll see a complete list, or an incomplete list, of the tribes living in what became known as the Northwest Territory, the regions north and west of the Ohio River and surrounding the Great Lakes. The tribes are grouped here as related by language. Beginning in the 1640s, pan-tribal movements formed among these tribes and others in the Great Lakes region to resist the expansion of the American European settlers westward. The asterisk movements below denote two major Great Lakes region pan-tribal alliances. And I'm going to skip through these treaties very quickly. Hold on. Oh, I want to just be able to see something for myself. I can't.
The treaties are on the screen.
Yeah, the treaties are there. There's something I want to get out of my way, but it won't go out of my way. Maybe I can. Anyway, sorry, very sorry about that. But so I'll skip quickly through these treaties. The first treaty of these are treaties that led basically to the shrinking of the Ohio lands for the peoples who were living here. So the Treaty of Fort Pitt was the very first one signed by the U.S. and a tribe after the Declaration of Independence. It didn't actually cede any, the Delaware didn't cede any territory in that treaty. But the next three, culminating in the Treaty of the Greenville Treaty, which created the Greenville Treaty Line, as you can see from the map, sequestered or confined the people who were living here to the very upper northwest corner of Ohio. So all that purple is land that was ceded in those treaties that came beforehand. The Treaty of Fort Industry, the next one down on the list, took another chunk out of that, the chunk from the Cuyahoga River to about Sandusky, which was part of the Connecticut Reserve, and we now call that the Firelands. The Greenville Treaty actually started or established the annuity system that you'll probably hear of more after this, of federal grants, yearly federal grants and goods to tribes. The settlers were not supposed to expand into the land, but they did, of course. The reserves were blocks of land within that north of the treaty line, north of the Greenville line, where, again, the land that was, there was land set aside for the tribes that were living there, and blocks of land, and those were the reserves. And the rest of the land was opened to settlers. So jumping ahead to the Indian Removal Act of Congress, this was an attempt to, well, it was granted the U.S. authority to negotiate treaties with tribes exchanging their land west of the Mississippi for the ancestral lands. Between 1830 and 1850, the U.S. government removed about 100,000 American Indians, opening more than 100 million acres of tribal land for American European settlement. And most people have heard of the Trail of Tears, and that often is referring to the Trail of Tears in the South with the Cherokee and the Southern tribes, which happened at the same time as what happens to the Ohio Native Americans. And you can read through a thorough account of the history of the Ohio Indians in the book called The Other Trail of Tears, The Removal of the Ohio Indians by Mary Stockwell. So 1843 to 1857, 116 years, there was virtually no presence of American Indians in Ohio. And I've just listed a few different things that happened elsewhere during that time. And then we'll scroll, I'll jump to 116 years forward to the Native American Relocation Act of 1956. That act brought American Indians and Alaska Natives from a wide range of tribes, unrelated tribes, to Cleveland. Hawaiian Natives were not included under that act. The Relocation Act was designed to break up reservations and tribal unity, enforcing assimilation into the mainstream U.S. culture. Originally voluntary, decreasing subsidies on reservations, incentives like financial aid, and the promise of opportunities and housing pressured people into choosing relocation. The program targeted working age individuals and families and those who were economically disadvantaged. When the Bureau of Indian Affairs started the program, only about 8% of Native Americans lived in cities. By 2000, roughly 64% lived in cities. Termination as a policy never officially ended, but the 1970s saw a shift in policy as reflected in the Indian Self-Determination and Education Act of 1957, the American Indian Religious Freedom Act of 1978, and the Native American Languages Act of 1990. With that, I will turn the evening over to Dr. Masis and Stephanie Ironshooter.
Thank you. It came up. That was really interesting, Nancy. Thank you.
Thank you.
We want to say thank you to those for this invitation. It's more meaningful than you probably realize. For me, I'll say because I've been in Ohio for 4 years now, after 35 years out west. And in preparing for this, I had just had all these associations and memories come back up. And besides that, I learned a lot. I want to say thank you to everybody that supported me and my family while we were trying to figure out how to get along. First, living on the Navajo Reservation, and finding out a lot of our habits were similar to other white people, and just learning, my gosh, all of this previously hidden information about the first peoples of North America. And I'm grateful that for everybody who's here and to the committee, the equity committee, and healthcare for all Ohioans for having us. Stephanie, would you like to say something?
I'd just like to say Wopila Tonka means a big thank you for being open-minded and being here with us this evening. And I couldn't help myself. I looked at the chat and someone asked what termination was, and we could talk about it at the end, but it is what it sounds like. So and I have to, just be honest with everyone and be very true and direct about my own experiences as an American Indian person growing up in Montana and as a part of the relocation at work. Termination is something that we are still fighting against in our communities, in our reservation communities here in the state of Montana. And I just really welcome you all to please don't be afraid to ask anything. Kathy and I feel are very open, and please don't think that there's a wrong question. And I get that a lot when I do these kind of presentations, and I don't want that. I want this to be a safe space for you. And I want to be, as I said, I'll be totally humble and direct about my own experiences. And I know Kathy will too. And I just want to just let you guys, all of you know, to be safe in this space. And I welcome any questions at all, please, no matter what they are. And again, thank you for allowing us to be here with you tonight.
Thank you. And I forgot to say Nancy, who spent a lot of time and effort preparing and helping us prepare for this. And Stephanie, thank you for going out of your way. This is above and beyond. Stephanie was called to help out on the Fort Peck Reservation, and she drove up there, and now she spent today, and now she's driving home, and you're pulled off. Are you in a parking lot or?
I'm in an actual gas station, and it's pretty bright. I moved my car, and there's a lot of hunters out, so I'll be expecting some deer on the way home. There's a lot of hunters in this parking lot, so.
Okay. I'm gonna go to what we want to cover in 50 minutes. So we will be going rapidly, and that's just the way it is. These were the topics that I came up with in order to answer the 3 questions that Nancy gave us about. Now I can't remember exactly what they were, but I know they're covered here. The health of Native, what are the disparities, and what's specific to Ohio, and how would single payer affect, especially American Indians in Ohio, but all over. So let's get started. This is being, you'll be able to look at these slides later because I know it's hard to keep track as we just go through this. I'm going to start out with how the National Indian Health Board describes the Native approach to health: body, mind, and spirit, a holistic approach. And I learned that's one of the things I learned very early in my Indian health career, that the Western European concept of individuality and of separating body, mind, and spirit, those traditions aren't shared by the Native people here. You want to say anything, Steph?
I just want to also, yeah, this description is very definitely very valid. And I just want everyone to know that even though, and I'm speaking from my experience with Montana and Wyoming in this region, which is the Plains, Great Plains area, is that we are bumping up against a system that was never meant for us. So whether it's the health system, education system, it doesn't matter which system it is, but that continual bumping up against, because that's not our way, and that's what our elders tell us. And that where I just came from in Fort Peck, this Lakota man from Pine Ridge was up in Fort Peck, and it's Assiniboine and Sioux up there, but it's usually not Pine Ridge, it's Dakota people that are from more like Saskatchewan area. But what he said was that our language and the well-being and the holistic way that we see the world, it's a different worldview than the Western mindset. And we have been, like I said, what I mean by that, we've been not just bumping up against it, but we are refusing to accept it. We're refusing to accept it because look what happened. The whole reason I was up in Fort Peck was because of behavioral health, mental health, suicide prevention, substance abuse, just the rampant, all these disparities that we're going to talk about is somebody said it directly, one of our elders today, colonization caused us to be in the position that we're in today. So that's a big statement, but hopefully we'll tease it out for the rest of the slides.
Okay, thank you. So here's the easy part. Well, actually, I'm kidding. Who was living here, and how are they counted? Because we're going to talk about disparities. You have to have data. You have to count people. So the term American Indian or Alaska Native is it includes the original peoples of North and South America. Those who they had their origins there, and they still maintain tribal affiliation or community attachment, which is why a DNA test does not make someone American Indian or Alaska Native. This is the US Census definition. And also, something to remember, that anytime you see census data that says American Indian, Alaska Native, AIAN, it's always not including anyone who checks Hispanic. So if you check American Indian and you also check Hispanic on the census form, you will not be counted as an American Indian. Okay. And I think I'll just I'll let you tell me if you need to say anything, if you want to say anything. Yeah. Oh, keep going. And here's a little bit more. Most Native people mostly identify with the tribe to which they belong. Okay, American Indian is the most common used term. 574 federally recognized tribes and Alaska Native entities. So Mexico isn't included. Canada isn't included, but Alaska is included. Native Hawaiians and Pacific Islanders are not included in American Indian and Alaska Native. Then there's the term Native American. And I highlighted here peoples. A member of any of the indigenous peoples of the Western Hemisphere it can be referred to as Native American. And it's usually used for US. Okay, so American Indians belong to tribes. And people ask about tribal membership. Stephanie?
Yes. Okay. So Dr. Masis mentioned 574 federally recognized tribes. The reason why that they're identified like that is really for federal funding purposes and treaty obligation line items, right? For membership. So 574 federally recognized tribes. So that means that each tribe or tribal government is sovereign, and they get to determine what blood quantum is makes them eligible to be a member of that tribe. However, the federal designation is a quarter in order to get Indian Health Service services, or and it follows through that we just kind of adopted the quarter system. 25%, you're 25% Native American, and then you get certain things like healthcare, and be a part of the treaty obligation fulfillment, whatever that looks like today. So each tribe gets to determine their own membership. So even though there's the quarter part for the federal funding, there's some tribes that do associate members. There's some tribes that have less blood quantum that make them a member of that tribe. Some tribes will combine with other tribes to make a whole for one tribe, like the Assiniboine tribes, one in Fort Belknap, one in Fort Peck. Fort Peck allows the combination. Fort Belknap does not. So it's very interesting and very complex. Each tribe gets to do what it wants around membership and whether they accept you to be a tribal member or not. So I've had sometimes for the 638 tribes, they allow non-tribal members to get services from their clinic because they're married to a federally recognized tribal member. That's just an example, and just to kind of iterate a little bit of the complexity of tribal membership.
Thanks. So now the first time we're bringing up equity, and I think that we've already, you're not going to be surprised to see that the National Indian Health Board says that they don't view health equity the same way that Western European American values, and you can look at all these. What is health equity? It's not just decreasing disparities, comparing data of what's happening in Indian country with the data on white people, or frequently US all races, is not what National Indian Health Board finds as the most useful. We're going to get to equity a lot. So that's just the first time we're going to introduces it. The Urban Indian Health Institute, I got some nice pictures from them. They were really concerned about data genocide. It was called, is called, during COVID. I know it became a really big issue during COVID. Do you want to say anything, Steph? Okay. So the numbers from the US Census that I found are here. American Indian and Alaska Native non-Hispanic and not in a combination of any other race, just alone, 6.7 million in 2020. There's 2024 estimates that they figure out with their magic at the census, but the census was on shutdown. I had trouble getting some of the data, so I'm just got 2020 here. Then Ohio. So there's almost 12 million Ohioans, 2024, and the percent. So what do I have? The number of American Indian, Alaska Native, Pacific Islanders, because there weren't enough AIAN to compute the data. So they didn't publish anything about American Indians and Alaska Natives in Ohio, just along with Pacific Islanders, and it's 0.6%. So Nancy, you found data on Native Americans, which is different from data on the legal term American Indian Alaska Native. This data thing it's crazy making. I see you're agreeing, Stephanie. And then there's a term, urban Indians, tribal people who currently live off federally defined tribal lands in urban areas. That's in the US, what do we call the lower 48, and also Alaska. Because in Alaska, they don't have tribal, they don't have reservations, it's more native corporations and villages. And so, and we don't have data on rural American Indians. Nobody publishes that. I learned a lot doing this. And I did find something, this came from the census, special place. In Ohio, the highest number, like a neighborhood of Native Americans, and they're called Native Americans in this, I don't know, is in downtown Columbus. Of all the cities, Cincinnati, Akron, Cleveland, there's not as many as in downtown Columbus. Highest percentage. Okay, here's another challenge. Well, I guess I learned from this. For the purposes of measurement, health equity means reducing and ultimately eliminating disparities in health and its determinants. And there are authors who have said, well, those situations where American Indians are doing better than, say, the white population, you don't want to see the white population, the native population descending and becoming more like the white population. That would be reducing a disparity, but not the way. I don't think that's a good idea. A few more of these hard to read slides. Average life expectancy. I'm sure you're interested in this. American Indian in the US as a whole, 70 years. Black, 74. White, 78.4. And white is the same as all races. It's the majority still. Hispanic and Latino live longer, and Asian Americans have the highest life expectancy. In Ohio, again, American Indian, Alaska Native, they did not compute life expectancy. I guess that's what I want to tell you about that. Life expectancy in general here is a little bit lower in Ohio. I think you've heard that before. And
Kathy?
yes, ma'am, go.
Oops, about 20 minutes from now.
Oh, I'm sorry. Stephanie, did you want to speak? Okay, we have 20 more minutes. The head of the Urban Indian Health Institute, which is based in Seattle, said a common saying in Indian country is that you're born native and you die white, because that's what they mark you on the death certificate, since nobody asks you. And that's an big issue in Native American data. So why is there an elevated mortality? This is somebody from the same reservation as Stephanie's mother, right? Joe Gahn, I'm going to mention him. That it has previously been attributed to lower socioeconomic status, and all, life is hard. But now the academic indigenous people who study indigenous people in the academy, in the universities, they are now looking at discrimination and cultural devastation. That it's now a subject. And as I said, this was a really interesting working on this. Things have changed as far as what is being published. For the better. There's another. Okay. American Indian, Alaska Native population has the highest uninsured rate of any of the racial populations. And here's so the Indian Health Service, I worked for them, is funded by Congress with US tax money. 60% of that appropriation is administered by the tribes. That's self-determination and self-governance. There may be more questions about that. That's the move towards self-determination has happened. So the Indian Health Service serves 2.8 million American Indian, Alaska Natives, and you have to be a member of a federally recognized tribe. IHS is in 37 states. The IHS says that the funding covers the user population at a rate of about $4,000 a year, where the US national per capita averages 13.5 per capita. The leading cause of death for American Indian, for people who are not elderly. Anyway, if you're under 55 years of age, and you're American Indian, the leading cause of death is unintentional injuries. And we don't have time to really get into the behavioral health issues. Oh, but I did have, we're going to touch on them. I forgot this one. So Ohio is part of one of the areas of the U.S. is broken up into 12 areas of the Indian Health Service. And if you were an eligible American Indian in Ohio, the closest place that you could go, because I clicked on this, is, oh dear, I forget. Canandaigua. No, Canandaigua is the closest Indian health center that you could go to. So
where is that?
Oh, it's
Western New York.
Back to the map. It is this picture, this icon. So here's Ohio, Pennsylvania,
New York.
New York.
Yeah.
It's not too far from Buffalo.
Oh, Canandaigua is in the Finger Lakes region.
Thanks. National single payer would be treated by the tribes as I assume, Steffi and I assume, the same way other federal funding that is not specific to tribes is dealt with. Stephanie, this is your topic.
So we talked a lot, Kathy and I, and I did a little bit of research on single payer health system, and actually what I'm sorry, I forgot your name. In the beginning, the test you gave us, or what healthcare coverage would we want, right? And ideally now, the second one should be the healthcare system as a federal trust responsibility for the American Indian population. It should be at 100%, at $13,000 or whatever it is, but we are existing in a 30%, actually 60% deficit to what a healthcare system should be in order to take care of us, as in help with our health. So it's desperately underfunded. So, say, for example, if a single payer health system was enacted, each tribe, as a sovereign nation, would decide on how that would be disseminated or agreed on or whatever, depending on what it is, because the single payer health system is what it should already be for the American Indian population. And we shouldn't have to pay for it at all. I mean, which we don't for the 33% that we do get from Indian Health Service. We don't necessarily pay for it, as in we don't have a copay, or you walk into an IHS facility as an Indian person, you don't pay like a copay or anything like that. And it's not health insurance. It's a federal trust responsibility. And that's something that Kathy and I talked a lot about, because there's a lot of misunderstanding about our healthcare system, the Indian Health Service, the tribal and the urban healthcare systems. It's a federal trust responsibility funding mechanism that is put forth through Indian Health Service or 638 contracts to cover our health care, again, as a deficit. So the single payer health system, again, like I said, would have to be determined by each tribe, 574 federally recognized tribes, on that. How would that impact them? What would it look like? Would the 638 still be an option? As in, because with 638, tribes that do contract fully, Title V, 638, when they do that, they are able to create revenue for their clinic services in a way that helps the tribe as a whole, I guess, as far as healthcare goes and revenue. So I'm just trying to see. I'm sorry, I'm looking at your slide here. I'm trying to see funding. Yes. Okay. Yeah. So that's really basically, generally speaking, Kathy, what I wanted to say about that is that it's a complex system that we live in as American Indian people, and the single payer health system is something that I think has been put forth from tribal, like your NCAIs, your NIHBs, or whatever, in a different kind of way to fulfill the federal trust responsibility. So I don't know if it would even pass through Congress at all, let alone for American Indian people, but let alone for the whole American population. It's a money, like it's all about the dollar, right? The bottom line. And this wouldn't make it so that America wouldn't have as much money, I guess, that's what I'm thinking. So, but anyway, that's all I have to say about that, Kathy. Thank you.
Thank you. This letter that I took, the concluding paragraph from the chairman of the National Indian Health Board to the houses of Congress about Medicaid, that I think that single payer, I could put single payer in here, any type of single payer, any type of change in the funding for Native American health would have to ensure that there wouldn't be significant funding shortfalls and must continue to preserve and protect. Oh, okay. I am not a single payer. This is something I don't know enough about, but the tribes, it's up to the tribes to deal with Congress, and they know how. I think we better keep moving. Looks like I skipped some. We just had a lot of sad discussion. The circle, the wheel, is how human life and community is looked at by natives. You want to say anything, Steph?
One person described the medicine wheel as it was a Western design meant to inform the Western population about our way of life and how we see the world, our worldview. So it's just a visual to describe to non-native people what it's like to be us.
Wow, thank you. And this is what it's like on the Blackfeet Reservation as far as self-determination goes. The Blackfeet tribe now has their own tribally run mental health center, and a couple of the things they offer, equine therapy and youth mentorships, and all kinds of mental health services, including cognitive behavioral. Healthcare for American Indians by American Indians is the movement. Okay, here's something else that is upsetting. Infant mortality, and especially maternal mortality, is higher. Alcohol-related deaths are 5 times. This is over a 13-year period here. 5 times higher American Indians. Notice that drug poisoning deaths aren't all that. I mean, it's a little bit higher. I thought that was interesting. I don't need to say anything more about that, except I found Urban Indian Health Institute, this poster. This is another example of how tribes and urban Indians take care of themselves. And we have to mention murdered, missing Indigenous women. I'm kind of tongue-tied. Steph, can you?
Yes, it's missing and murdered Indigenous people, actually, is what it changed to. It's not just women. I mean, we're talking men. We have elders that have been missing. So it's persons now, and there's a lot of effort going on around MMIP now.
Okay, thank you.
We probably, if you want to save the 15 minutes for questions and answers, you probably want to wrap up in a few minutes here, just
in a few minutes. Okay.
2 or 3 minutes. Yeah.
Okay. That speaks for itself. And healthcare racial equity it's recommended that the investment be made in tribal, culturally appropriate ways. Reclaiming our indigenous data practices. Historical healing. Almost the last slide. I liked how these two Indigenous authors talked about the broad concept of being well achieved through relationships to other people, to the land, to creation, and to our ancestors in the spiritual realm. And we are wrapping up. Steph, do you want to have, before we have questions, did we skip anything?
No, I think that's a lot to take in. So I really would just like to open it up for questions, because I know that was a lot of information, but I'd just like to open it up. And plus, you all will get to have the slides. And honestly, any questions you have or follow up that you'd like to have with Kathy or we both welcome any outreach to us with any additional questions or conversations you want to have about any of this that we talked about.
Thank you, Dr. Masis and Stephanie. Do you want to stop your screen share, Dr. Masis, and then we can open it up for questions? Kurt, I see Kurt has a hand up.
Bob, I think Bob was before me. Bob had his hand up first. It's just that
I noticed
his wall paint color obscured it.
I noticed one characteristic of your presentation was that instead of your education being directional, meaning from point A to point B, it was rather circular, and it went up in sort of a spiral. You went around and you touched on something, and then you went around and you touched on it in a different perspective, and so on. That seems to be characteristic of Native American education, spirituality, lore. Would that be a good statement?
Do you mean how we presented the information?
Yes.
Right. So I think you're exactly right. So our worldview is very holistic, and I use that word because, like, right now, I'm thinking about when you're in our communities and you're around our people, and if like we ever get to meet, you're going to notice the difference. And being able to make sure that it's all like it, somebody said today, it's a circle. It doesn't have a beginning and it doesn't have an ending. And that's how it is. And it's alive at all times. It's alive at all times. And so you can't consider one without the other when you're talking about like all the stuff we're talking about. It doesn't matter what the health disparity is, the answer's the same. The reasoning for it is the same. But you could take any one of those and put it in there and talk about it in the same way that you would talk about any other thing. So it's really cool to be able to look at things like that because that makes it simpler. You don't have to pick out individual things and just beat it to death. It's a pretty very simple process that we use, and it's just hard when people make it complicated sometimes to explain it.
Kurt?
Thank you. I'll answer the VA question now. So the eligibility is kind of similar. Veterans are eligible. What's different is the determination of whether you can get services for a specific health issue. It depends on the funding. Sometimes it's raised and sometimes it's lowered. Sometimes you have to have a service related issue in order to be served. Are there any veterans here who can talk about this? The VA, I don't believe, bills Medicaid for different from the Indian Health Service.
They don't.
The VA in Tucson doesn't keep the money that I don't know enough. But it's not like there's a tribe that runs the VA in Tucson. It's all inner. It's all in the same system. Thanks for the question, because it's an interesting comparison.
Kurt?
Yeah, when I first started getting involved in universal healthcare and the single payer movement, I read a lot about systems, some of them being Native American systems. And I was interested in the cultural differences in the Nuka system, the Alaskan Native system. I don't know how much you guys know about the African or the Alaskan Native system, but if you think about the geography, Alaska is a big chunk, and then it's got all the archipelago of islands, and a lot of different tribal customs and how should I say, cultural norms. In one area, it was easy to do a medical history because the tribes were very verbal and had that tradition. In others, they were closed up and not communicative. Could you speak to that a little bit?
I can. So Alaska Natives are covered in the Indian Health Service Tribal Urban, the ITU, that's federally funded. But well, so while you were speaking, I was picturing the Anchorage Alaska Native Health Center in Anchorage is one of the premier hospitals in the country.
Like Mayo or something.
Mayo, yeah, you're right. and there is so much research done up there. We know what you're talking about. They know about all the issues that you are mentioning, and they deal with them. It is a marvelous system that is more self-determination than what's in the lower 48. The Alaska corporations deliver more services directly than the lower 48.
Thank you.
Marlene?
Yes, I'm trying to put everything together, but one thing that I think is an advantage in many ways um, with the American Indians / Native Americans is looking at the whole picture and not separating out each part of the healthcare system. You understand how behavioral health cannot be separated from environment. There's many good things about it, I do believe. We have in the rest of the nation much more individualized thinking. And I can see where that could be a problem. So what I'm wondering, what if we had a single payer system, but it offered in the delivery of the system um, for each tribe to um, use the funding or whatever for what you have on that particular reservation, um, would that work so that you had some determination with that, and yet you are part of a fair system where nobody's left out? And if there are needs, you will have those needs met, even if they're maybe different from the next group.
Well, I guess historically, there will be parameters set in place that would actually make it so that there's barriers to doing just that. They wouldn't allow, like, for instance, there was a question that's actually related to what you're asking. Are there medical education curricula and accreditation set up for tribal practitioners? So it's just now, Dr. Masis, just now, like in the past 5 years, been okay, and we're allowed, to integrate traditional tribal practices into this Western healthcare system in different ways. And I think that's what you're asking. But they talk about best practice, promising practice, those kind of practices, and it has to be those and accepted by actually mostly when they do research on it, it's for the white population, not for the American Indian population. So taking that into consideration is something that I'd be amazed if the federal government or Congress or whatever actually gave some leeway in where that we can use and they could just believe that they work for us, traditional tribal practices for our own healthcare. I hope that answers your question.
If you are credentialed by the traditional practitioners, several of the hospitals on the Navajo Reservation, a quote medicine person can be reimbursed for services. And I don't know how they do that, but I've seen photographs of traditional hogan shaped rooms set aside in Navajo hospitals.
Oh,
Kathy.
Hi, thank you both very much. I put a question in the chat, and I guess you haven't seen it, but how does a Native American in Ohio get health care, and how is it covered? Do you go to your, the same doctors that we would go to and submit a claim through the
No.
Indian health system? What?
No. Wow, what a good question. It's right on the money. There's no funding for American Indian healthcare that's outside of the Indian Health Service, T, tribal facilities, and U, urban. So if you are a member of a tribe and you are eligible for Indian Health Service,
You're the one that they are.
and you live in Ohio, there's nothing for you. So I looked up on the Indian Health Service website because they've got a thing that says, where can I get care? So I looked up where can I get care? And they did have an answer in Ohio, and they referred me to 2 different community health centers, which are open to whoever's, I don't know if there's a, who's eligible at community health centers, if it's everybody, but if you're eligible to go to a community health center, then you can get services there, but it has nothing to do with being Native American. Again, Native American is not recognized as a status. There's no legal, it's just a term. It's just a piece of our.
So could a Native American working for a company, some organization, would that person have health care coverage through their company? And if they're retired, would they have Medicare?
They would have Medicare. The Indian Health Service bill is the payer of last resort.
I see.
So whatever else you have, even if you live on a reservation, if you have, right, Stephanie, if you have insurance, private insurance,
Right.
that's billed first, and Medicaid and Medicare are billed. Thank you.
Thank you.
One of the things I would respond to is your question about would healthcare under Medicare for all be of help to Native Americans? And you could say to them and everybody who are in those systems is absolutely. That would be that would override and use the funding from all the other federal health organizations to help pay for it. And it would supersede any of the other systems that are available. Now that would probably need to be integrated into the Native American Indian health systems in some fashion. But I would say that that the people in the recognized tribes in the USA ought to be rooting for Medicare for all as much as all the rest of us are, because it would benefit you.
Well, I think, Bob, I myself don't feel I'm not a tribal leader of a sovereign nation, but there's definitely something that I want to make sure that everyone understands is the complex difference and the political designation that each tribal nation has to determine their own health trajectory. So what does that mean? Does that mean, so like if they do go to the one payer, so when you said supersede, that scared me a little bit because I'm like, supersedes the treaty obligation? Do you know what I mean? So and tribes might, I mean, I would say tribes would ask a lot of questions on how is this going to impact what we already have in place.
What the what the healthcare legislation says is that you can go to any licensed provider. And so I presume that the people in the tribal lands would be licensed providers. So that would continue. But you may have to negotiate, like you have negotiated with these other, with Medicare, Medicaid, and all those systems, S-chip. You would have to negotiate with them, it sounds like, from your tribal perspective. But I would say it would be a real benefit to you because the funding would be there.
I think Nancy is indicating that we are, she's putting up the poll.
Put up the poll.
That we're done for now.
Well, maybe this would be a good time for Stephanie and Dr. Masis to give us any last thoughts or remarks that you want to make as we come to a close.
I want to say, Stephanie calls me Dr. Masis. That goes back how many years? 13 when we worked together. And
well, first of all, thank you all for all your wonderful questions. And I know this is bigger and beyond the scope of this sit down. So please reach out to us. And I would love, Bob, especially, I would love to talk more about it. And I'm very interested. I would love to hear what a tribe in Montana would think about it. And I'd be happy to provide a white paper of some sort just to see what they thought. I would love to do that. So, and I have all the opportunity to do that. So Bob or whoever else, I'd be glad to take a look at something, a white paper, something that we can propose, just totally propose and see what they'd say.
We can send you a copy of the Ohio legislation, and you can look at that. We just had it introduced into the Ohio House, and it's pretty much a short summary of what Medicare for All is.
I think it's interesting maybe in bringing that subject up, though, like Bob, we don't have any federally recognized reservations here and any federally recognized actual tribes here. So I wonder if that would make a difference in, I mean, we might not even address that in our law, in our proposed law anyway.
Right.
And so that would make a difference. And as I think Stephanie was indicated, you have for the Indian Health Service, that comes under treaty obligations,
Right.
which of course have been broken many times in other ways, but that one has sustained, even though it doesn't pay for everything, right? So don't know if that is of interest.
I want to, my last words are, thank you so much. This feels, it felt like a lot of cohesion, even though you were all, a lot of you, just these little tiny squares with your face. I felt really comfortable. This is a difficult subject that in a way I don't really have the right to speak about Native American health. It was only because Stephanie agreed to be here. Stephanie, and I'm grateful to all the Native Americans who have corrected me on all the mistakes that's how I learned, is by making mistakes. Yeah. So I also appreciate your willingness to get out there and just ask a question and not be shy. Thank you. Thank you, Nancy.
Thank you, Dr. Masis. Thank you, Stephanie. Thank you, everybody, for coming this evening, for joining us this evening.